This module will give you a quick background into Lynch syndrome. It has been created as a quick guide for primary care clinicians and will last for approximately 8 to 10 minutes. This module will introduce what is Lynch syndrome, the clinical management of patients and their at-risk relatives, and the recommended surveillance for patients and their relatives. Lynch syndrome is the most common inherited cancer predisposition syndrome. It accounts for about 3% of all colorectal and 3% of all endometrial cancer cases. Lynch syndrome was formerly known as hereditary non-polyposis colorectal cancer syndrome, or HNPCC, but this term is no longer used. Lynch syndrome affects 1 in 270 people in the UK. Unfortunately, we only know about 5% of the people affected by Lynch syndrome. People living with Lynch syndrome have a significantly higher risk of developing cancer. The main concerns are colorectal and endometrial cancers. They are also at risk of developing cancer in other sites, although less frequently. These other cancers include ovarian cancer, urinary tract cancer, gastric cancer, small intestine cancer, hepatobiliary and pancreatic cancer, sebaceous gland cancer and edemas, and central nervous system tumours. Lynch syndrome is caused by germline pathogenic variants in one of 4 DNA mismatch repair genes, which includes MLH1, MSH2, MSH6, and PMS2 genes. There is a 5th gene associated with Lynch syndrome. Deletions in the 3' end of the EPCAM gene can also cause Lynch syndrome through the inactivation of the neighbouring MSH2 gene. The cancer risk in Lynch syndrome is variable. The cancer risk is gene dependent and tends to be highest for MLH1 and MSH2 alteration carriers, although MSH6 carriers may be at highest risk of endometrial cancer. Lynch syndrome is not typically associated with a significantly increased risk of childhood cancer. The cancer risk is age dependent and increases with age. The cancer risk is also sex dependent, and colorectal cancer risk tends to be higher in male carriers compared to female. Lynch syndrome is inherited in an autosomal dominant manner. What this means is that first-degree relatives, that is the parents, siblings and children of someone affected, all have a 50% chance of having the same pathogenic variant. Knowing whether a cancer has been caused by Lynch syndrome provides important information for the patient and their unaffected family members. For patients with cancer, this may provide an explanation for why cancer occurred, a predictive biomarker of treatment response and/or prognosis, and information about secondary cancer risk and prevention. For unaffected family members, this may inform future cancer risk, permit implementation of cancer screening and risk-reducing interventions, and provide couples with a reproductive option of pre-implantation genetic diagnosis, an IVF-based technology which allows embryos to be screened for familial genetic pathogenic variants, therefore allowing couples to have a baby who does not carry the familial pathogenic variant. Unaffected relatives of Lynch syndrome patients can be referred to their local genetic services if they want to discuss predictive genetic testing for the familial MMR pathogenic variant from the age of 18. Predictive genetic testing should only be performed by specialised genetic centres. The cancer risk in Lynch syndrome can be managed by regular colonoscopy with polypectomy. Current UK guidelines recommend that this is performed from the age of 25 or 35, depending on the individual's gene pathogenic variant, and should be performed at 2-yearly intervals. Regular low dose of aspirin from the ages of 25 to 65. A low dose aspirin is recommended to be taken daily for at least 2 years. This was shown by the CAPP2 randomized controlled trial to reduce the long-term risk of cancer in individuals with Lynch syndrome by up to 50%. Trials to determine the best dose of aspirin for cancer prevention in Lynch syndrome are still ongoing. For now, most specialised centres recommend 150 mg daily for individuals with average weight and 300 mg for individuals with BMI above 30. NICE has produced a decision aid for patients with Lynch syndrome with this information. It can be accessed through this link. The link is also available in the quick guide leaflet for your convenience. One-off screening for Helicobacter pylori. Eradication of H. pylori reduces the risk of gastric cancer by around half in Lynch syndrome. Gynecological surveillance. Currently, there is limited evidence about the utility of gynecological surveillance for early detection of endometrial and ovarian cancer. Risk-reducing surgery is offered because there is no effective screening test. However, this should be a personalised decision, generally offered from the age of 40 once they have completed their families, taking into consideration their risk factors, genetic mutation, personal preferences, and quality of life. Consider referral of women around the age of 40 for a discussion around surgery to clinical genetics or specialised centres. Family planning for pathogenic variant carriers. Consider referral to clinical genetics for a discussion about embryo selection as part of PGD or pre-implantation genetic diagnosis, an IVF-based technology which allows embryos to be screened for familial genetic pathogenic variants, therefore allowing couples to have a baby who does not carry the familial pathogenic variant. Lastly, Lynch syndrome patients with colorectal cancer are eligible for targeted treatments. As part of this short learning resource, a quick guide leaflet has been created. It will guide you into what to consider when you see a patient with Lynch syndrome, who you can refer to as index case, and what to consider when you see one of their first-degree relatives in clinic. We will use the guide in these two common case scenarios: a patient diagnosed with Lynch syndrome after their cancer diagnosis, a first-degree relative of an individual with Lynch syndrome. Scenario 1. John is 44 years old and was diagnosed with colorectal cancer 4 years ago. Due to his family history, he was offered genetic testing. He was given a genetic diagnosis of Lynch syndrome due to a pathogenic variant in the MLH1 gene. During your consultation, you find out that 1. He doesn't know much about Lynch syndrome. 2. He hasn't had a colonoscopy for the last 3 years. 3. He is not plugged into the system. 4. He hasn't told his family. The guide will help you identify the main concerns for this patient. Lynch syndrome should be coded as a problem in the primary care record. As he had a diagnostic genetic test following his cancer diagnosis, as per ABI Code of Genetic Testing, this will be considered with his insurance application as John had a diagnostic test. However, his previous cancer diagnosis and family history of cancer will have more weight in his insurance application than his genetic diagnosis. He is due his 2-yearly colonoscopy. He needs to be referred for a colonoscopy to gastroenterology promptly. He hasn't got any symptoms or concerns. However, if he had any symptoms which could be linked to any of the Lynch syndrome associated cancers, he will need prompt investigations. He is not on aspirin. Consider prescribing aspirin or giving the patient a copy of the NICE decision aid, which can be found by following the link in the quick guide. He hasn't been tested for H. pylori. Consider testing. If you had a female patient around the age of 40 who has completed her family, consider referring back to their genetics or specialised centre to discuss the benefits of prophylactic surgery. John seems to have educational needs and hasn't informed his first-degree relatives about their risk. Consider referring back to his genetics or specialised service for a discussion about Lynch syndrome and family screening. Overall, following this assessment, the guide has helped to identify that John needs prompt referral to gastroenterology for a colonoscopy and referral to his genetics or specialised centre for education and family screening. It has also identified that he could benefit from aspirin and testing for H. pylori. Scenario 2. Mary is 23 years old. She came to clinic because she would like to start a family. Her father has a genetic diagnosis of Lynch syndrome due to a pathogenic variant on the MSH6 gene. During your consultation, you find out that 1. She doesn't know much about Lynch syndrome. 2. She has mild PR bleeding. 3. She doesn't know that she could benefit from predictive genetic testing as she is over 18 years old. The guide will help you identify the main concerns for this patient. Lynch syndrome should be coded as a problem in the primary care record. This information is not considered within insurance applications as per ABI Code of Genetic Testing and Insurance because she never had cancer, even if she was found to have the pathogenic variant and she hasn't had genetic testing. However, her family history of cancer will have some weight in insurance applications. Consider referral to your clinical genetics for predictive genetic testing and family planning. If she is found to have the pathogenic variant, she will be eligible for the additional reproductive option of pre-implantation genetic diagnosis, an IVF-based technology which allows embryos to be screened for familial genetic pathogenic variants, therefore allowing couples to have a baby who does not carry the familial pathogenic variant. She will be due a 2-yearly colonoscopy from the age of 35. However, she has bowel symptoms and should be referred to gastroenterology for a colonoscopy using the 2-week pathway. If she had any other symptoms which could be linked to any of the Lynch syndrome associated cancers, she would need prompt investigation for those as well. She is eligible for genetic testing. If she declines predictive genetic testing and hasn't had testing by the age of 35, refer to gastroenterology for 2-yearly colonoscopy. Overall, following this assessment, the guide will have helped you to identify that Mary needs prompt referral to gastroenterology for a colonoscopy and referral to her local genetic centre for predictive genetic testing and family planning. If you would like to find out more about Lynch syndrome or the genetic counselling process, we recommend that you continue with the online training for the endometrial or colorectal MDTs option 1, which can be found in the e-learning for health platform. You have now reached the end of the teaching module. Further information and the quick guide leaflet for primary care clinicians can be found in the below website addresses.